Behind every successful breast surgery, there's more than precision, there's purpose. Today we go in the open with Dr. Lyronne Olivier. He is a skilled breast surgeon who brings empathy together with his skill in the fight of breast cancer. Dr. Olivier, thank you so much for taking the time. I know how busy you are to come speak with me and to educate the women about what to expect and what goes into their care when the decision comes to have breast surgery.
Yes, thank you for having me. It's an opportunity to bring awareness about breast cancer.
Yes.
And to let patients to know what to expect.
Thank you so much. But before we get to that, to the technical stuff, tell me, what brought you to this field, breast surgery?
It's an interesting story. I mean, I really wanted to do something that was surgical because my initial training is general surgery.
Yeah.
And then I wanted to find something that could make a difference. And I know in Trinidad, our numbers of breast surgeons were very limited. I think when I initially got the concept of doing breast surgery, we had one breast surgeon in Trinidad.
Okay.
So I think there was a need for both public and private patients required a breast surgery.
Yeah. Yeah. And how long did it take you to get through that journey to become Dr. Olivier, the breast surgeon?
you know, I think it starts. So recently, my mom celebrating 50th year anniversary as a dental nurse, and I had to write a piece for them. And I think it starts even before that. It starts from that initial onset where I learned how to interact with patients, how to learn how to interact with their relatives. And I think I learned that from my mom, highlighting that. But that's where it starts. It starts with empathy.
Yes.
And it starts with understanding your patients. And then the training itself, it's a process we all have to go through. You went through your training as well. So I did general surgery first. That's a post-grad training. Yeah. And then I did my fellowship training in Toronto in breast surgical oncology in 2020.
And it's interesting that you said your mom is a dental nurse and that gave you a unique perspective into medicine. My mom is an operating theater nurse, a midwife, a district health visitor. And so my first interaction with pregnant women and the birthing process was being with my mom on her home deliveries.
Yeah. So you learned that initial
exactly. So that's where I got the love for it. And of course, wanting to do a surgical field, not like yours, but something to do with surgery is because she was a operating theater nurse and I would peep in and see them in their greens. And it was just, I have to do that. But let's get back to the script.
Yeah, for sure.
How common is breast cancer?
So breast cancer is the #1 cancer in the world for women. Okay. In terms of, we use the medical jargon, incidence. So it occurs the most in women in terms of cancer. And in terms of cause of death for cancer, breast cancer is the #1 cancer. That's internationally, and that is mirrored in Trinidad as well. So the #1 cancer in women in Trinidad is breast cancer. And the #1 mortality from a cancer in women is breast cancer. So, for example, I always quote this data. It's a bit old, from 2014 to 2018. That's a 5-year period. We had 1,982 women diagnosed with breast cancer. And we had 1,100 women died from breast cancer. So if we do the crude yearly event of breast cancer, it was about 550 women that diagnosed with breast cancer. And we had over 275 women died from breast cancer. And we know this data is old. We know we are improving in our system in accounting and data collection and what have you. So that data probably don't mirror exactly the quantity of burden of breast cancer in Trinidad.
That's some pretty alarming data though. We for some reason, it doesn't come across that way in terms of the awareness that we see. We don't hear these startling numbers, on TV, on television. We don't hear it like that.
But that's where this starts. This is where it starts. I mean, anyone asks me to come and give a talk on breast cancer. I was in Point Fortin about 2 weeks ago. It's about awareness. Because we know as physicians, we want to find something before it manifests clinically.
Correct.
We want to talk about screening, we want to talk about awareness, we want to find a lesion before it becomes palpable. So the greatest chance for cure.
Yeah. I remember growing up that two of the cases of breast cancer that stand out in my mind were actually women that to me were young. And they had at the time young children. Tell us, what actually is the age that most women would become ill with breast cancer or diagnosed with breast cancer?
I think the trend, I'm a tertiary, where I work is a tertiary center, so I see a lot of breast cancers.
Yes.
But I think there's a general trend for younger age.
Yeah.
And this is seen internationally as well, because the initial screening, as you will know, was 50.
Yeah.
So when I did my training in 2020 in Toronto, it was 50 we start screening. Now internationally, both in Trinidad and throughout the world, there's no debate about it. It's at age 40.
Right.
So that alone tells you that the age for breast cancer diagnosis is obviously coming down.
Coming down.
I have 25-year-olds, I have 31-year-olds, I have 35, 36, 40-year-olds, 50-year-olds. So the trend for age of breast cancer starts very early. It's all about risk assessment.
Yeah.
You need to know your family history. You need to know your medical history. And you need to know if, for example, you have a mother who had breast cancer.
Right.
The general consensus is you should start screening 10 years before.
Okay.
So really, the awareness really needs to start with your history and knowing yourself. But you know, it's about risk stratification as well. You know, so there are certain risks that will put you for breast cancer, and there are risks that we talk about modifiable risks, risks we can change, and risks we cannot change.
Correct.
And some of the risks that we cannot change are, one, being a woman.
Yes.
So just being a woman alone, you know, it's 1 in 8 women will get breast cancer. That's a 12% lifetime risk.
Yeah.
You know, age at which you start seeing your menstrual cycle, age at which you end your menstrual cycle, all those are factors that determine breast cancer. But one of the most important one is people always feel, I'm sure you have met patients, I have nobody in my family who had breast cancer. How did I get this?
Right.
Only 10% of breast cancers are linked to a family history.
Okay.
90% is sporadic, meaning that we don't know the cause. So you know, there's a lot of things that we still don't know about breast cancer, but there are some modifiable risk factors which we can talk about. And it's always an interesting topic, because one of the main ones is alcohol. Yeah.
Alcohol.
So I know culturally in Trinidad we drink alcohol, but there's a direct correlation with alcohol and breast cancer.
Okay.
So I would say limit your intake or abstain from it as much as you can. And you know, those are the general risk factors that you can be concerned about.
And it's important that we talk about, although you say it's a small factor that's familial, our aunts and our grannies of old, they would hide things from us.
Yeah.
They wouldn't tell us what was their ailment. We just know that they passed away, or we would find out when it was very late. So I think, as you said, things like this bring awareness, and it helps us to speak about issues such as this in the open, so that we take away the taboo, we draw the curtains back. Come on, let's talk about it. This is what I had, and this is what I'm going through, and you need to get checked as well. We have the famous story of Angelina. Her mom was ovarian or breast, and she went and she did double mastectomy, oophorectomy. Prophylactically, she removed everything. Is that something women should consider if truly they find out that they are at risk by the gene?
So again, it comes down with risk stratification. And there are certain criteria we fulfill to determine who should get genetic testing.
Right.
So some people, if you're diagnosed with breast cancer under the age of 50, if you have one breast cancer before the age of 50, another breast cancer after the age of 50, if you have a certain type of breast cancer called triple negative breast cancer, family history of ovarian cancer, breast cancer, male breast cancer, those are some of the indications we'll do genetic testing.
Right.
If you do deem that you have a mutation in your gene, and mutations can be good or bad. So let's just, simple terms, bad mutation. In a mutation in a gene, for example, BRCA1 or BRCA2 and PALB2, those are the three that we recommend generally considering prophylactic mastectomies. And prophylactic means that the breast that is unaffected we consider to remove. So there is a scenario where you should, because if, for example, if you have BRCA1 or BRCA2, you have more than a 50% lifetime to get a breast cancer. And then you're not only prone to breast cancers. In your field, they are prone to ovarian cancers, fallopian tube cancers. So there's a whole risk stratification. But that's where we are now. And that's why breast surgery management is not just myself, it's a team. So you're going to meet the medical oncologist afterwards. You have a radiation oncologist. We all work together to plan the management for the patients.
It's a team.
It's a team.
It's a team. Your patient has come to the point where she needs to have breast surgery, and you are in the room talking to her. What is that conversation like? What are you telling her about the risks, what to expect in her surgery? Talk to us about that.
So, I mean, firstly, there's a lot of steps before that, you know, and that's where we have evolved in breast surgeries. It's not just focusing on the surgery, but if we have come to the point about breast surgery, I always start off saying that breast cancer surgery has two main components. Because when you talk about breast cancer, you need to stage the cancer, and that's what the surgery does. It brings the pathological staging, the staging from removing the tumor and assessing the nodes.
Right.
So we have two parts in the surgery. We have surgery to the breast and surgery to the armpit. The surgery to the breast is going to give us the size of the tumor, the stage of the tumor, and surgery to the armpit is going to let us know if the cancer cells has gone to that lymph node basin or starting to spread into the body. Breast surgery aspects, you have two main components. So I always tell patients, it's either we decide to preserve the breast or we decide to remove the breast. If we decide to preserve the breast, there's certain treatments like radiation you need to have. If we decide to remove the breast, I always offer patients things like reconstruction. So we can talk about it later, but there's no difference in terms of removing your breast or preserving your breast in terms of your survival. And what that means is that you're not going to live longer or live less if we remove your breast or preserve your breast. Some studies actually show now that if we preserve your breast, there is an increased survival. But if you preserve the breast, we know that you must have additional treatment like radiation. So that's where I come in, and that's where my passion is now, is about oncoplastic surgery. We start talking about removing the cancer in oncology techniques and reconstructing the breast with your own tissue and making your breast maintain awesome shape and symmetry and to maintain your femininity. And then if we go down the route of having to remove the breast, there are things we can do. We have skin sparing mastectomies, nipple sparing mastectomies. We can put in balloons, put in expanders, put in permanent implants. We could use your own tissue to recreate a breast mound and a breast for you. So there's no need to have a scar and a flat chest. That whole dogma about once you have breast cancer, you must remove your breast, that's no longer acceptable.
That's really, really interesting. But what is the timeline between your initial removal of, let's say, your lump, your breast, and any kind of reconstructive surgery?
So ideally, it should be done at the same time.
Really?
So if I remove your tumor, in terms of preserving your breast, we use oncoplastic techniques one time to maintain the shape and symmetry of your breast, and sometimes we do work on the other breast to make them look same. And if it is that you're doing a mastectomy, we have immediate reconstruction and we have delayed reconstruction. The one you're speaking about is delayed, but we have immediate where we do it at the same time, and that gives you the best cosmetic outcome. So we can do it at the same time. So we need to debunk all these things. So I actually have an article, hopefully should be published soon, where I'm talking about myths about breast cancer, and these are things that we highlight. I could probably send you that, and you could probably post that as well. But those are some of the things that we need to do this awareness. I mean, we can never cover everything today.
No, we can't.
There's so much things that we have to talk about, but I think we need to start, and this is where we're bringing everything out in the open, so we can lead to letting patients be more educated about what to expect.
And what are this 4 to 6 weeks after surgery, what does that look like for the patient?
So that 4 to 6 period is about recovery. It's about support. I think we're going to talk, someone is going to come and talk about family support and all of that as well. And then there is the element of recovering from the scars and the suture removals and the dressings and all of that. But also it is important for us to get the pathological staging. That's where we get the results. That's where we can actually tell you. Everything was an estimation before. Everything was a clinical staging. Now we have a pathological staging. What's the size of your tumor? What stage you are, stage 1, stage 2, stage 3, what treatment you need to have. So that takes us now into the aftermath. Does this patient need additional treatment like radiation, etc.? And are you a part of the team discussing that as well as a surgeon? Definitely. I think even before, so one way to break anxiety is to educate. So that should be all discussed initially. So you know what to expect at each step of the time. And I think management should also they should have a basic plan beforehand, and Dr. Nimrod will discuss these things, because there's a whole trend about treatment before, treatment after, after the surgery to that regards.
All right. So what would you tell a woman who's afraid to just go get her mammogram done?
I think it's important that early diagnosis gives us the best chance for cure. And I think it's also important to know that mammogram is part of screening, and screening is the ability to pick something up before it becomes clinically apparent. The stage of your breast cancer obviously increases survival. If you're diagnosed at stage 1, your survival is 99%. So if you pick your cancer up before it becomes clinically, it's early, it's less than a centimeter, it's in a mammogram, then your greatest chance for cure. So your survival is greatest. Your treatment might be a lot less as well because you're diagnosed earlier. So go get a screening, because that will lead us to the opportunity for cure.
Thank you so much, Dr. Olivier.
It's a pleasure.
Thank you for being here. And I learned a lot just by having this simple conversation with you. And I know that our women out there would learn as well.
Awesome.
Dr. Olivier reminds us that healing isn't just about procedures, it's about people. Where purpose meets precision, medicine truly lives in the open.